So this lecture will cover the basics of drugs for the peripheral nervous system and drugs of the central nervous system. So what we'll do is we'll start off with an overview of how drugs work within those two branches of the nervous system, and then we'll look briefly at drugs that are relevant in the peripheral nervous system, and then start looking at drugs that are relevant in the central nervous system. So when we talk about the peripheral nervous system, we're really talking about the autonomic nervous system. And the autonomic is divided into two branches, the parasympathetic and the sympathetic. So the drugs that we're going to cover are mainly drugs that actually alter what happens within the sympathetic nervous system. But I'll go through an overview of both branches of the autonomic nervous system and then focus specifically on drugs that are used commonly within the sympathetic nervous system. All right, so just some basic principles of neuropharmacology. So basically, neuro means nerves, pharmacology means drugs. So basically, neuropharmacology is study of drugs that change what happens within the nervous system. So as I said, two categories. And over here, you've got all the various and varied functions that drugs can actually affect within the neuropharmacological arena. So just to remind you, this is a neuron, and you know the neuron, you've got the cell body over here. Neurotransmitters are made within the cell body, or I should say T, just to follow this nomenclature. And the transmitter is transported all the way down to the axons, where it is, or it waits in the axon terminal for a signal to be released. And so you see over here the T is released, and then the T binds to the receptor, and then that has an effect. All right, so a couple of things. One of it is process number one. So process number one is called axonal conduction. And axonal conduction is really mediated by the sodium ion. And so what happens is when sodium ions go into the axons, what happens is the nerve the action potential is propagated down the axon. And then as it reaches the axon terminal, what happens is it changes the membrane potential in here, and then it causes calcium to actually enter into the axon terminal. And when calcium enters into the axon terminal, these vesicles or packages of transmitters fuses with a membrane over here, and then releases the transmitter. And this process of the transmitter release from the axon terminal and the transmitter binding to the receptor is called synaptic transmission. And then obviously, in order for it to have an effect, the transmitter needs to bind to its specific receptor, and then that act of binding of the transmitter or ligand to the receptor will actually start the effects in the receptor. Now, another thing is that when you look over here, as I've said before, drugs only alter what the body can do. So the drugs that affect the nervous system either do two things. One is that they can simulate the action of the endogenous ligand. Right? So if this is the heart, and the endogenous ligand or the transmitter increases heart rate, what happens is the drugs can either be agonist and also act similarly to the endogenous ligand, or it can be an antagonist and block the activation of the receptor. So an antagonist in this sense would actually decrease heart rate, whereas an agonist would increase heart rate. All right, let's get going. So just general concepts with neurotransmission. You can see over here there are 5 different steps listed on the right hand side. So the first step within the neurotransmission process is the synthesis of the transmitter, right? So you've got over here just the precursor compounds that actually are altered in order to actually form the final transmitter. And then step number 2, the transmitter is stored and packaged in vesicles. And then at some point, the transmitter has to be released in step 3. That's with the influx of calcium. Will make the vesicles bind to the membrane and then fuse with the membrane and then release the transmitter. And then, as I said, as the transmitter is released into the synaptic cleft, it binds to its specific receptor and then has an effect in the postsynaptic cell. And the postsynaptic cell can be another nerve, can be a muscle, can be a gland. And then at some point, what happens is the transmitter dissociates from the receptor. And then when it dissociates from the receptor, it can do one of 3 things. First one is it can go back into the presynaptic nerve terminal, the terminal that the nerve that actually released it. And often when it's taken back into the nerve that released it, what happens is it can either be repackaged into those vesicles, or it can actually be degraded. It can be metabolized into inactive components, right? And so this is called reuptake, when it basically returns to the nerve terminal that releases it. So an example of some neurotransmitters that undergo reuptake are epinephrine, norepinephrine, 5-HT, and dopamine, right? The second option for termination of action once the transmitter is released from the receptor is it undergoes enzymatic degradation. So an example of a neurotransmitter that undergoes metabolism right at the synaptic cleft is acetylcholine, right? And then a third possibility is it basically just diffuses away, and as it basically leaves the synaptic cleft, there's less chance of it binding to receptor and then having an effect. All right, so having knowing that, what happens is we're going to look at an overview of how drugs either increase or decrease receptor activation. And remember, if you increase receptor activation, that means you're basically imitating the effects of the endogenous ligand, which I'm going to put T. If you decrease receptor activation, then basically what you're doing is you're blocking or decreasing the effect of the transmitter. All right, so let's see. So what happens when you block the first step in the pathway? Oh, when you alter the first step on the pathway. So if you increase the transmitter synthesis, that means there's more transmitter being made, and so you increase the receptor activation. If you decrease the amount of transmitter being made, that means there's less transmitter that can actually go through the process, and so you decrease the receptor activation. If you decrease step 2, the transmitter storage, then there's less transmitters that are found in the vesicles and less transmitter that are able to be released, and so you decrease receptor activation. Now, step 3 is the release of the transmitter from the axon terminal. So again, if you increase release, you increase the receptor activation. If you decrease release, you decrease the receptor activation. The fourth thing is if you the fourth part of the process is if you increase receptor binding, you increase the effects of the receptor activation. If you decrease receptor binding, you decrease the effect of the receptor activation. If you actually block the activation of the receptor through the use of antagonists, then what happens is you decrease the effect of the receptor activation. Okay. Now, step 5 is termination of transmission activation. So again, if you decrease reuptake, so this is step 5A, and this is step 5B. So let's go to this. So one of the ways that neurotransmitter action is terminated is if it goes back in there. But what happens is if you actually block this action of 5A, what happens is it means that there's more transmitter in the synaptic cleft, and if there's more transmitter in the synaptic cleft, there's more transmitter that's able to bind. So if you decrease reuptake, then what happens is that you increase the receptor activation. And this is how selective serotonin reuptake inhibitors that are used as antidepressants actually work. And then the last thing is if you actually decrease the transmitter breakdown. So if you actually block this pathway, if you block the enzyme, what happens is that there's an increase in the amount of transmitter that are present in the synaptic cleft. So you increase the amount of activation of the receptor. And so if you decrease breakdown, then you increase the amount of receptor activation. And these are an example of a group of drug that does this is called the cholinesterase inhibitors, and they are used to manage the symptoms of people with Alzheimer's disease. All right, so now we get to the autonomic nervous system, the peripheral nervous system. And again, this is just a reminder. So anytime you have a slide with a background color to it, it means that it's not directly examinable for the purposes of this course. So again, we break up the autonomic nervous system into sympathetic and parasympathetic. And if you can see over here, the sympathetic nervous system is involved in fight or flight reflex, whereas the parasympathetic nervous system is involved in rest and digest. So let's look at the parasympathetic nervous system first. So with rest and digest, it basically is the predominant nervous system when someone's at rest, right? So you've got resting heart rate and contraction, normal blood flow, normal blood pressure. When you eat, you've got normal digestion and absorption. You've got normal secretion of enzymes, digestive enzymes and saliva and mucus and all that kind of stuff to help the digestive process. In terms of breathing, normal rate and depth of breathing. The bronchioles, or the airways, are fairly narrow because you don't need that much air just to sustain life. And the receptors that are involved in this parasympathetic nervous system are called cholinergic receptors, because what happens is they bind to the neurotransmitter acetylcholine. And these are nicotinic cholinergic receptors, can be again subdivided into nicotinic and muscarinic subtypes. So the parasympathetic nervous system is just the system that keeps you ticking over. So if you look at the diagram of the heart, you can see over here, and I know that these are flipped, you can see the parasympathetic nerve basically slows down heart rate, and what you can see here is the heart is one of the many organs in the body that have what's called dual innervation. And dual innervation means that it has inputs from both the parasympathetic as well as the sympathetic nervous system. So again, parasympathetic nervous system, normal resting heart rate, and when you need to run away from the bear or what have you, the sympathetic nervous system kicks in and it speeds up heart rate. So let's go look at briefly at the effects of the sympathetic nervous system. So you can see over here in the heart beats faster and stronger to try to get more blood out to the muscles, and essential organs that are needed to run away and make decisions. And so blood flow to non-essential organs, mainly the digestive tract, shut down. So digestion shuts down, right? And you can see this inhibits digestion and absorption. And then the blood is then diverted to the skeletal muscles and heart. Right? So again, obviously not all the blood is diverted to skeletal muscle and the heart, but more blood is diverted to those areas, which will enable the body to prepare for fight or flight, right? Blood pressure goes up, again, to basically drive blood through the body, and you need more air and more gas exchange, so breathing becomes faster and deeper, and the airways become wider. So the receptors that are specific to the sympathetic nervous system are called adrenergic receptors, basically because adrenaline or epinephrine was one of the first compounds to actually bind, is the endogenous compound that binds to the adrenergic receptors. And you can see here, adrenergic receptors can be again subdivided into alpha and beta subtypes. Now, we've talked about many different receptors and receptor subtypes, and again, I'm going to show these two diagrams. So what you have over here is you have, in the diagram in the top right, what you have is you have acetylcholine, and acetylcholine is the endogenous ligand and is the neurotransmitter, right? And then you've got exogenous ligand or drugs, nicotine and muscarine. And what you can see here is acetylcholine will bind to both nicotinic cholinergic receptors and muscarinic cholinergic receptors. So if you see a double-barreled name in front of the word receptor, you can see this is the main receptor type, and then the first part of the double-barreled name is the name of the subtype. All right, so what's the importance of selectivity and receptor subtypes is this. So say you have these two creatures, and what happens over here is I say A is basically epinephrine. All right, so when epinephrine is released, what happens is it has an effect on the heart. It basically increases heart rate and force of contractility. It slows down digestion, right? It increases blood flow to the muscles, and it also affects the kidney, and it also causes release of adrenaline or more epinephrine from the adrenal medulla, right? So what happens is that if you have someone with, and then it also affects, I'm going to draw very bad lungs over here. It also increases air going into the lungs and the force of breathing as well as the rate of breathing. All right. So if you give someone a shot of adrenaline or epinephrine, it will actually affect all these various places in these specific ways. Now, say Merv has asthma, but he also has he's also had a couple of heart attacks. He's also had a couple of myocardial infarction, and really what he wants to do is he's having an asthmatic attack, right? So if he's having an asthmatic attack, what you want to do is you want to increase the amount of air going into the lungs, but you don't want to actually affect anything else. And so what happens is, luckily for us, the bronchial smooth muscles in the airways actually are a very specific subtype of adrenergic receptors, and these are the beta 2 subtypes. And so what you do is if you give Merv a drug that only affects the beta 2 receptors, it can selectively open up the airways and have no effect anywhere else, right? Because and again, I'm going to go through that later on. The adrenergic receptors in the heart are the beta 1. The adrenergic receptors in the blood vessels are the alpha 1. Okay, so again, if you can develop a drug that's specific to a receptor subtype, it means it affects only those receptors that are associated with those receptor subtypes, those locations that are associated with receptor subtypes, and not any other receptors anywhere in the body. Right? So again, that selectivity is actually the most desirable quality a drug can have, because what it does, it can alter a disease process, in the example asthma, without actually affecting the heart, digestive system, blood vessels, and so on, right? What often happens is this. So you remember, most drugs are not 100% selective, and what happens is if you actually have someone who's an asthmatic inhale a much larger than normal amount of beta 2 agonists, what happens is it can actually get into the systemic nervous system, systemic circulation, and affect other receptors, other adrenergic receptors. All right, so again, we'll look at that as we go along. So there's 3 types of information needed about a drug. First of all is you need to actually know which receptor type or receptor subtypes the drug affects, right? So if you have epinephrine, the type is adrenergic, and epinephrine actually affects the various subtypes, so alpha 1, alpha 2, beta 1, and beta 2 receptors. So those are the receptor subtypes. And then you need to know what happens when the drug actually, what happens when the endogenous ligand binds to the drug at the location, and you need to know whether the drug is an agonist or an antagonist. And so that's also the third part, right? So you need to know type, receptor, subtype. You need to know what normal endogenous ligand does, and you need to know whether the drug is an agonist or an antagonist. And so this agonist and antagonist should actually be included in the last point. All right, in terms of autonomic nervous system and neurotransmitters, what we have over here is we have a ganglion. And remember, a ganglion is a collection of cell bodies in the peripheral nervous system outside of the CNS. So if you look over here, I'm going to just highlight something. So a ganglion is this area over here. The preganglionic neuron is the neuron that's before the ganglion. So this is the preganglionic neuron. And then the postganglionic neuron is the neuron that's after the ganglion. So that's a postganglionic neuron. And then the effector cell is the cell right at the end of the pathway that the postganglionic cell affects. All right, so again, that's just a brief overview. Now, in the second diagram, what I'm going to go through is very quickly go through this various terminology. So cholinergic neurons are neurons that release acetylcholine. So these are cholinergic neurons, right? So you can see there's cholinergic neurons in the somatic nervous system that control the skeletal muscle, cholinergic neurons in the parasympathetic nervous system, and cholinergic neurons also in the sympathetic nervous system in the preganglionic neurons, right? So all preganglionic neurons are cholinergic, and the postganglionic neuron in the sympathetic nervous system, in the parasympathetic nervous system, is also cholinergic. Now, cholinergic receptors are what the acetylcholine binds to. So these are, you can see N2 over here on the somatic nervous system and 1 on the postganglionic neuron. So it binds to the acetylcholine that's being released by the preganglionic neuron. And then also you've got M, muscarinic receptor subtypes on the postganglionic neuron of the parasympathetic nervous system, and also, just as an exception, on the sweat gland that's innervated by the sympathetic nervous system. So I missed out on this. Okay, and then you've got receptor subtypes. So the receptor subtypes are the nicotinic cholinergic receptors. So these are the nicotinic cholinergic receptors. And you've also got the muscarinic cholinergic receptors. So these are the muscarinic cholinergic receptors. And then you've got adrenergic neurons. I'm gonna run out of color soon. So adrenergic neurons are neurons that release adrenaline or epinephrine, and so these are, or norepinephrine. These are adrenergic neurons. And then adrenergic receptors are those receptors that bind to norepinephrine and epi, right? So these are adrenergic receptors, and you can see over here that there are different receptor subtypes. For adrenergic receptors, you've got beta adrenergic receptors over here, and you've got alpha adrenergic receptors on various muscles. Okay, so those are it. All right, so now we go to the good stuff. We're going to look at drugs. So the first type of drugs we're going to look at are called sympathomimetic. So if you look at the name, sympatho refers obviously to the sympathetic nervous system. Mimetic means it imitates or is similar to. And so because these drugs imitate what the sympathetic nervous system does, they're referred to as adrenergic agonists, right? So you've got the main clinical uses over here. And then you've got just some different drugs over here. If we look at the chemical structure of the drugs in the adrenergic agonist category, you can see that they're divided into two different categories, catecholamines and non-catecholamines. And what this does is that these, it refers to basically how quickly they are metabolized by different enzymes, right? So you've got monoamine oxidase, and then you've got catechol-O-methyl-transferase. So these are the two enzymes listed in full. So catecholamines are metabolized quickly by these two enzymes. And so what happens is, because there's rapid metabolism, catecholamines, when they're administered, they have a very short half-life. So again, it gets broken down quickly, so the effects are very short-lived. Right? Now, because they are broken down extensively by these enzymes in the liver and small intestine, they cannot be given orally. Right? Because what happens is they're given orally. You've got almost 100% first pass effect, and then 0% actually gets into the systemic blood flow, systemic circulation. And so these drugs are usually only given parenterally. Because these drugs are polar, they don't cross into the blood-brain barrier, which is good because then they don't have any central effects. All right, non-catecholamines are the opposite of catecholamines, so they're metabolized by monoamine oxidase very slowly, so they've got a longer half-life. They're not metabolized as extensively by those MAO enzymes in the liver. So they can be given orally, right? Because again, you've got some bioavailability so that it can actually enter into the systemic circulation and have an effect. Because they're less polar, a proportion of non-catecholamines do cross the blood-brain barrier. So what we're going to look at is we're going to look at specifically at activation and blocking of different subtypes within the adrenergic system. So the first subtype of the adrenergic system we're going to look at are alpha-1 receptors. And alpha-1 receptors are found on smooth muscle in the blood vessels. So if you look at the blood vessels in the picture, you've got smooth muscles in the tunica media, right? In the elastic artery, in the medium-sized vein and muscular artery, and as well as you have a very small amount in the venule and arterial, right? So what happens is when alpha-1 receptors that are found in these smooth muscles are activated, it basically leads to vasoconstriction. All right, so what are some therapeutic applications where vasoconstriction is a good thing? So you've got over here just a list of 5. And so what happens here is with hemostasis, if there's localized bleeding and you want to stop that bleeding, then alpha-1 receptors are good. And again, on that note, as an adjunct to local anesthetic, so if a local anesthetic is given, what happens is a local injection of epinephrine is often given as well, and that basically slows the absorption of that anesthetic into the general systemic circulation. Vasoconstriction is also a therapeutic application with a runny nose, because it can cause vasoconstriction of the blood vessels in the nose and cause nasal decongestion. It can also lead to increased blood pressure and dilation of the radial muscle of the iris. All right. In terms of the adverse effects, again, because it causes vasoconstriction, what happens is if the vasoconstriction is too pronounced, it can lead to hypertension. Right. So you see it over here, and also it can if the blood vessels are vasoconstricted, what happens is it can impede blood flow to certain regions of the body and eventually cause necrosis. Now, some alpha receptor agonists are selective, but what happens if it's given at a high enough dose, then selectivity is lost. And so what happens is if you give a specific alpha receptor agonist at a high dose, it will start to affect other adrenergic receptors, mainly the beta 1s and beta 2s. The other thing to note in this slide is you've got the therapeutic effects in the green box, and you've got the adverse effects in the red box. And again, that's just to make things easier. So you've got therapeutic, go, and adverse effects are not desired effects. Another type of adrenergic receptors subtype are the beta receptors. So beta receptors are found on cardiac muscle, and what happens when they're activated is that it increases heart rate, it increases contractile force, and so it helps to pump more blood. It helps with cardiac output. So cardiac output is heart rate times stroke volume per minute, and it also helps to push blood to various tissues in the body. Right, so therapeutic applications, because it increases cardiac output, it's used in shock to try to push blood to vital organs. It's used in heart failure to try to increase cardiac output. It's used to overcome atrioventricular heart block, to try to get the heart moving, and also in cardiac arrest when it's used to actually restart a heart that stopped breathing, right? And again, the adverse effects are pretty much based on the mechanism of action. So if you increase heart rate so much, it can lead to tachycardia, and if you affect the conduction, right, of the heart, it can cause dysrhythmias. And again, the act of increasing cardiac output means that you increase the demand for blood and oxygen, and so that might actually overcome the ability of the blood vessels to actually supply enough blood, and that might actually cause chest pains or angina pectoris. And again, just a note, selectivity of drugs to receptor subtypes usually relative to dose, and at high doses the selectivity is lost, can be lost. The third type of adrenergic receptor subtypes are beta 2 receptors. So beta 2 receptors are found in the smooth muscle of the bronchioles as well as in the uterus. All right, so you can see over here the bronchioles are found, you can see over here, they're all bronchioles over here, and so they basically control the amount of air that actually gets in and out of the lungs, right? So again, therapeutic application of beta 2 are those situations where you need more air to get into the lungs in asthma. All right, so beta 2 receptor agonists are used for bronchodilation to help relieve or prevent asthma attacks. And again, because it causes smooth muscle relaxation of the uterus, then it's used to delay preterm labor. All right, so that's a drug that's selective for beta 2 receptors that's used to delay preterm labor. Now, the other location that beta 2 receptors are found are in skeletal muscles and in the liver. And what happens when beta 2 receptors in the skeletal muscle and liver are activated is that they cause glycogen to break down to glucose. So this is what's called glycogenolysis. So glycogenolysis is when you've got glycogen being broken down to glucose, and then glucose is released into the blood. And so when you have an increase of glucose released into the blood, you run the risk of hyperglycemia, especially with diabetics, right? Other adverse effects are tachycardia at high dose, because selectivity is lost at high dose. And then you've also can get skeletal muscle tremors, which is a common and temporary effect of beta 2 receptor activation. So you've got over here some non-selective adrenergic receptors. You've got epinephrine, and you've got here the uses of epinephrine listed over here. You've got norepinephrine that activates 3 out of the 4 adrenergic subtypes, so it does not activate beta 2, so it means that it has no effect on uterine or bronchial smooth muscles. And then you've got isoprotenolol, which activates just the beta receptors. So beta receptors are found in the heart, beta 1 are found in the heart, beta 2 are found in the lungs. All right, so again, norepinephrine used for some of the same uses as epinephrine, whereas isoprotenolol has no effect on blood vessels, and so it's again used for similar things as norepinephrine and epinephrine. In terms of adverse effects, you can see over here, these are effects that are due to activation of alpha-1 here, hypertensive crisis. Dysrhythmia and angina are effect of beta-1 on the heart. Necrosis after activation, alpha-1. Hyperglycemia is an effect of beta-2. Right? Although the hyperglycemia is not really seen with norepinephrine. And isoprotenolol, because it has no effect on an alpha-1, it has no effect on blood pressure, right? So again, this dysrhythmias and angina are due to activation of beta-1 receptors on the heart, and hyperglycemia and diabetes are due to activation of beta-2 in the skeletal muscle and liver. Same 3 drugs, but what we're going to look at are contraindications and drug interactions, right? So again, these drugs, because they're catecholamines, they're very rapidly inactivated by the 2 enzymes listed over here. When given at the same time as monoamine oxidase inhibitors, what happens is that monoamine oxidase can't work because it's been inhibited by MOAI, and so the effects of epinephrine and norepinephrine are prolonged specifically. And again, with TCAs, they also affect the metabolism of epinephrine and norepinephrine, and the pathway of epinephrine and norepinephrine, and so those effects are intensified. General anesthetics here work on the myocardium to make it super sensitive to beta-1 activation, and beta-1 activation is done with any of these 3 drugs. And so what happens, it can intensify the adverse effects, right? And then again, another drug interaction is beta blocking agents, because then it basically cuts the beta-1 effects, stimulating effects of these 3 drugs. Okay, so what happens is beta blockers, or beta adrenergic blockers, are actually sometimes used to treat when there's too much epinephrine or norepinephrine or isoprotenolol floating around. Beta blocking agents are given to actually decrease the effects of epinephrine and norepinephrine. Right? Epinephrine and norepinephrine also affect alpha receptor subtypes, and so again, if given with alpha blocking agents, it may actually decrease the effect of epinephrine and norepinephrine on blood vessels. And again, it's a common way to actually treat excessive alpha activation. All right. Now, some of you may wonder why I haven't talked much about alpha-2 receptors. And you can see over here in the diagram below where alpha-2 receptors are located. So we're talking about alpha-2 receptors. And alpha-2 receptors are actually located on the neuron that actually releases the transmitter. And so these are called presynaptic neuron, and we don't actually talk a lot about it. So these are called presynaptic receptors. So it has a it's not relevant for the purposes of this lecture. All right, so that's why I've skipped it. Now we're going to look at blocking of the adrenergic receptors. So in this one, we're talking about blocking of alpha receptors, right? So more adrenergic antagonists are most adrenergic antagonists are more selective than adrenergic agonists. So again, alpha receptors are found on smooth muscle of blood vessels, and so if they're blocked, it means that it causes relaxation of those smooth muscle, and so it causes vasodilation. All right, so which situations actually call for vasodilation? So again, I've got an example of various drugs that act as alpha adrenergic antagonists. You don't have to memorize those drugs per se. And I've got here a list of therapeutic applications of alpha receptor antagonists. So the first one is obviously if you want vasodilation, that's required, or that's nice to have if you have hypertension, right? So it causes vasodilation in arterioles, and if you have vasodilation in arterioles, blood pressure goes down, and what happens is that the heart doesn't have to work that hard. Alpha adrenergic antagonists are also used to reverse toxicity from drugs that activate the alpha-1 receptors. It also is used to manage benign prostatic hyperplasia, because what happens in BPH is similar to what happens in blood pressure, in hypertension. So if you've got hypertension over here and you've got BPH, what happens in hypertension is that you have the blood vessels over here, the pressure in there increasing, and it causes the heart muscle to work harder, right? Whereas in BPH, what happens is you have the bladder, and then you have the urethra, and in BPH, what happens is the prostate gets bigger, and the pressure inside of the urethra increases, and so the smooth muscle of the bladder needs to work harder in order to push urine out. Right? Smooth muscle of bladder working harder in order to push urine out is very similar to the heart needing to work harder in order to push blood out of it. All right. So again, what happens is that this relaxes the smooth muscle contraction in the prostate and bladder, so it's easier to manage. Pheochromocytoma is a tumor in the adrenal medulla that secretes epinephrine. And so if you secrete epinephrine, it actually causes, and this is an ongoing secretion of epinephrine. So if you think about your adrenal gland secreting epinephrine all the time, what happens is your blood pressure will actually increase. Right, so you have hypertension, and so what happens is alpha blockade will actually reduce the hypertension caused by an excessive amount of epinephrine floating around. Raynaud's disease is when you have the blood vessels in the toes and fingers spasming at random times. And so what happens is alpha-1 receptor blockade will actually cause vasodilation of those blood vessels in the toes and fingers and then cause symptomatic relief. All right, so it means that instead of having white fingers and toes, your finger and toes have got a normal color, and you've got the right amount of blood flowing through it. You don't have that tingling and numbness as part of the Raynaud's disease. Over here, what we're going to talk about is adverse effects of alpha blockade. So you can see here, most adverse effects are from blocking of the blood vessels, so it's due mainly to vasoconstriction, right? Oh, sorry, the block of vasoconstriction, so it's due to vasodilation. So what happens when blood vessels dilate is that you can have what's called orthostatic hypotension. So orthostatic hypertension is a drop in blood pressure when a person goes from a supine to a sitting, from a sitting to a standing position, right? And what normally happens is when we go from supine to sitting, sitting to standing, is that normally our sympathetic nervous system kicks in just for a very, very short period of time, but the sympathetic nervous system kicks in mainly to actually cause vasoconstriction, to actually push blood up to the heart and to the head. Now, people who have who are taking alpha antagonists basically can't vasoconstrict as well, right? And so what happens when they're moving from supine to sitting, sitting to standing, is that it can't constrict, so blood basically pools in their extremity, in their legs, and then you've got less blood going to the heart and less blood going to the head, right? So related to orthostatic hypotension is first dose effect, which happens with the first dose for a person who's not used to taking alpha antagonist, or person who hasn't taken it for a long time. You have that dizziness, and sometimes people can actually faint from the orthostatic hypotension effect. The other thing is, because you have vasodilation and because you have a drop in blood pressure, sometimes you have what's called reflex tachycardia. So because the blood pressure drops, what happens is the heart says, oh, we're not getting enough blood running around through our body, so let's speed up the heart rate, right? And so what happens is you end up with tachycardia. That's part of this nerve reflex. You also get, as part of the vasodilation, is you get vasodilation of the nasal mucosa, so you can end up with nasal congestion, because the sympathetic nervous system is involved in ejaculation. If you block that, you can inhibit ejaculation, and this is reversible when the drug is discontinued. And because the sympathetic nervous system is also involved in the renal angiotensin-aldosterone system, what happens is that blocking of the alpha receptors can actually cause a sodium retention and increase blood volume, right? Mainly due to the drop in pH, right? If you have a drop in pH, you want to increase blood volume, and so you have sodium retention and increased blood volume as a result of that drop in blood pressure. This is overcome using diuretics here. So that's with adrenergic receptor blockade. This one is from beta adrenergic blockade. So again, we're blocking beta receptors, right? So almost all therapeutic effects are due to beta blockade. And so a nickname for beta adrenergic blockade are beta blockers. And so you've got over here metoprolol, selective for beta receptors. Propranolol blocks both beta 1 and beta 2. All right, so in terms of the therapeutic applications, you've got it listed over here. So if you want, basically, if you block beta 1 receptors are found in the heart. are found in the heart. So if you block it, what happens is you decrease heart rate and you decrease contractile force. Right? You stop the heart from working as much. And so these are used for stage fright, for that tumor in the adrenal medulla, and for hyperthyroidism. Right? So what happens is it basically decreases heart rate, decrease tachycardia, decreases force of ventricular contraction, and also decreases impulse conduction through the AV node, so it decreases heart rate. Right, so the heart doesn't work as much as hard. In glaucoma, it has elevated intraocular pressure, and so it acts to actually lower that. It's sometimes used to prevent migraines, and you can see here unknown mechanism, and you can see over here 1, 2, 3, 4 are related to the effects on the heart. So you can see here it's used to treat angina, to reduce the possibility of myocardial infarction, to manage heart failure, and to treat cardiac dysrhythmias, because what happens is it decreases conduction, impulse conduction through the AV node, right? And then it's also been shown to actually be helpful in hypertension, because it reduces the peripheral vascular resistance, right, over a long period of time. So these are the therapeutic applications, and you can see how it actually relates to how it works on the specific tissue, in this case the heart. The slide talks about the adverse effects. So adverse effects are due to both beta 1 and beta 2 blockade. So again, beta 1 would be reduced heart rate and reduced stroke volume and contractility, and then beta 2 are in the lungs, so it reduces airflow, right? And it causes bronchoconstriction. All right, so what are the adverse effects of beta blockade? So you've got over here, this is the effects on the heart, right? Bradycardia, reduced contractile force, reduced cardiac output. You've got precipitation of heart failure, even though they're also used to treat heart failure, so it can actually make heart failure worse. It can cause heart block between the atrioventricular conduction pathway, because it slows it down so much that it can actually block it. It can cause rebound cardiac excitation, especially when the beta blockers are withdrawn suddenly. So because what happens is with an antagonist, it can actually make the receptors much more sensitive to the presence of the agonist. So if you stop the beta blocker suddenly, it can actually cause rebound cardiac excitation. And then because it blocks beta 2 receptors, it can cause bronchoconstriction, right? Which is not to be desired in people with asthma. It can cause hypoglycemia due to beta 2 blockade in the muscle and liver. Again, very important to watch for in people with diabetes. Beta receptors are also found in certain blood vessels that supply the skeletal muscle, and so it can cause vasoconstrictions of those blood vessels. Some beta blockers can cross the blood-brain barrier, and propranolol then blocks norepinephrine receptors in the central nervous system and cause depression. And then specifically in neonates and newborns, it can actually cause decreased heart rate, respiratory distress, and hypoglycemia. And it's even more important, specifically more important to actually watch for in newborns. And that's it. I'm going to stop recording now because that's long enough, and I'll do the CNS in another recording.